presentation is a rare case of vancomycin-induced linear immunoglobulin A bullous dermatosis. Linear immunoglobulin A bullous dermatosis, LABD, is a rare subepidermal blistering disease. It is often linked to a medication, infection, or underlying autoimmune disease, and can be confused with other bullous diseases, such as Stevens-Johnson syndrome and bullous pemphigoid. We present the case of an adult that developed a severe maculopapular rash and multiple bullous lesions involving almost 25% of her body while receiving vancomycin. So this is a 69-year-old female on vancomycin therapy for a recent MRSA cellulitis that had developed at a previously inserted IV site, as shown in Figure 2. On day 6 of vancomycin therapy, the patient started to develop vesicular lesions on her mouth, palms, and soles, initially concerning for hand, foot, and mouth disease. Over the next 24 hours, she developed a fever and tense bullae with erythematous bases on the limbs, trunks, eyes, mouth, and vagina, as shown in Figure 3. Nikolsky sign was positive. Vancomycin was discontinued on day 7 due to concerns for a drug reaction. Dermatology prescribed prednisone and obtained a skin biopsy, and the patient's condition improved significantly over the next 2 weeks. She was transferred to the burn ICU for wound care, where ophthalmology and OBGYN were consulted for management of mucosal lesions. Final histopathology showed subepidermal bullae with neutrophils. Immunofluorescence showed continuous linear IgA deposition in the basement membrane, consistent with drug-induced LABD, as shown in Figure 1. Discussion. Only 2 to 3% of LABD are reported to be drug-induced, most frequently with vancomycin, which is often prescribed for numerous MRSA-related infections. Vancomycin is associated with many skin manifestations, such as red man syndrome, drug reaction with eosinophilia and systemic symptoms, and Stevens-Johnson syndrome. LABD, though rare, should also be considered, as it can also result in similar lesions. The presentation in our case was atypical, with initial mucosal manifestations, which is rare in drug-induced LABD. Diagnosis is via skin biopsy, followed with tissue histology and immunofluorescence. Treatment is discontinuation of the drug and adjunctive treatment with dapsone, with improvement within a few weeks. Due to the severity and rapidly progressive nature of LABD, management must involve an interprofessional team at the first signs of an adverse drug reaction. Although rare, autoimmune conditions such as LABD should be considered as part of the differential diagnosis of drug-induced reactions. It is important to recognize that mucosal symptoms can be the inaugural manifestations of such conditions, and once diagnosis is made, it can direct the management and therapy choice. Thank you.